quality needs to be driven by at least a champion or a focal person. Whereas we know that quality spans across all the directorates if it's the Ministry of Health or even the county health departments, we have got programs. They have different quality improvement initiatives.
Hi everyone, welcome to the See It Do It podcast series. See It means to see linked data, and do it means act on the data.
Let's make every contact count.
Core concepts in quality improvement.
Doing things differently.
Mentoring, support, supervision, and coaching.
Client perspective.
Data quality, digitization, and research.
We are See It, Do It. Hello and welcome to the See It, Do It podcast series. My name is Vicky Doyle. I'm a quality improvement advisor for the See It, Do It programme. Today, we're going to be talking about the core concepts of quality improvement and quality assurance. What does that really mean in practice? And I'm delighted to welcome to the studio today Dr. Charles Kandia. So please introduce yourself a little bit.
Yes, thank you very much. I'm Dr. Charles Kandia. I work in the Directorate of Health Standard Quality Assurance and Regulation in the Ministry of Health. And the Directorate is responsible for inspiring quality improvement, not just in public sector, but also private sector and faith-based organization. And it also spans across the two levels of government, the national government and the county government.
Thank you. So we're delighted you're here with us. We know you have a lot of wisdom you can share with us, and you've been a key figure in Kenya for many years now in really pushing the needle and getting people to really embrace and embed quality improvement into all aspects of how we provide health services. So before we start the questions, I like to start with a provocation. And the provocation for today is quality is everybody's business, yet quality is nobody's business. And yeah, we've seen that in many countries. Everyone says, of course, quality is important, but then who's driving it? So perhaps just a few reflections on that, Charles.
Okay, thank you very much. When it comes to quality needs to be driven by at least a champion or a focal person. Whereas we know that quality spans across all the directorates if it's the Ministry of Health or even the county health departments, we have got programs. They have different quality improvement initiatives. So it's important that we have one directorate or a focal person or a coordinator driving quality. And this is important because if it's left on its own, if we say it's everybody's business, then you'll find nobody does it. And it's very important that we have.
And we've seen this in many countries, globally, this phenomenon where everyone says we're committed to quality, but then nobody knows where to start. And maybe that leads into my first question to you, actually, is we see lots of national guidance, standards, policy, which is there to guide people. But how does that translate to quality improvement actually being implemented on the ground? And here I'm talking about in facilities and at the community level. How do we translate those standards to on-the-ground reality of quality improvement?
Okay, thank you very much for that question. So normally we say from paper to action.
Yes,
so
I don't like paper policies.
Yes, exactly. So as Minister of Health, when we it's important that once documents are done, it should be launched and disseminated to all the counties, and also ensures that it also reaches to the health facilities and also community health units. So from where I sit, I saw that there was need for us to do sensitization, first of all, to the leadership at the county level and also leadership at the hospital levels for them to understand this. So they need training. So they need to be sensitized and trained on quality improvement initiatives on the documents we have come up with. We have got a number of documents. We came up with quality of care, KQMCH, which means Kenya Quality Model for Community Health Standards.
I was very pleased to see that one.
Yes, and those are the ones that now they're being used. And we had a scale program that came and supported in its implementation and gave us ideas on how we can make it better. So how do we do it? It's training, and then secondly, ensure that so training alone does not make an impact. It needs to be followed up by mentorship and coaching.
Okay. So let me ask you that, because I think this is really important. Yes, we need to sensitize. Yes, we need to train. And as you rightly said, training alone is not going to solve it. It's about, so really, what is the role of the county and the sub-county in supporting the frontline workers? And when I talk about frontline workers, we're talking about community health promoters, we're talking about ANC nurses, facility staff. What is the role of the county and the sub-county in really, I suppose, mentoring, coaching, supporting them to improve quality?
Yes, thank you very much. So counties, especially at the both at the county level, we need to have proper governance, quality improvement governance systems. So these governance systems by the counties need to be trained properly. They need to be initiated on quality improvement tools, and then they are told they need to have quarterly meetings for them. So they are the ones who are supposed to guide the quality work improvement teams at the county level, not the county level, at the community level, so that they understand it. And their role is also to link the communities with, especially the community health promoters, the CHAS, with the health facility, the link facility, so that they become the spoke, and then the health link facility becomes the hub for them. Okay. Yes. So that is so it's very important that the governance system is strong, they are trained, and their role is to empower communities. In fact, one of our big ideas on quality of care is that we need to empower communities to demand for quality. And who best can do that is the community health promoters, telling what is their expectation, what they should demand for when they go to when they seek care at the community units or also at the health facilities.
Okay. Because what I've seen in many countries is that we have a lot of good documents supporting quality improvement, but it often stops at the facility level. And yet we know that community health is the bedrock of the health system. And actually, how do we make sure that we're having a more integrated approach to quality improvement so that it doesn't stop at the facility level, it goes right down to the community level, which is where we're really going to see those changes?
We have got Kenya Quality Model for Health, where one of the tenets is partnership with the clients and the community in terms of service delivery. So it's very important that the community is linked with the nearest link facility. And this, how do we approach it or structure it, is through forming work improvement teams at the community level, where the stakeholders will come from the people the healthcare providers at the health facility, then the top leadership, or what you call opinion leaders within the community, to be involved in the work improvement teams, so that they can discuss, look at what are the gaps and how they can improve quality of health services within the community. So it's important. So that is done in a structured manner. One of the 2 or 3 members are part of the community, are part of the link facility committee. So it's important. So that is the linkage that needs to be done. Initially, it was not. So as we were cascading quality improvement, we were only focusing up to the facility level. But we found that it was important that we focus up to the community level, and that's how that's why we are now coming to the healthcare work. The community is telling them now the role of improvement of services within your community health units is with you. Not so it is all of us working as a team.
Yeah. So quality starts at the community level, really. And I think one of the things I think a lot of the work that the See It Do It program has been trying to focus on is looking at that interface between community and facility and trying to strengthen the links between the two. Because I think that's going to be the only way that we can really get a seamless continuum of care between those two levels. So I don't know if you've got any other comments on how we can strengthen that interface, because that often is where we get the breakdown, where a CHP might bring a pregnant woman to a health facility, and yet the health facility doesn't know who the CHP is. We have CHARs, the community health assistants, who are supervising them. They may not be part of the health centre. So it's trying to strengthen that interface so that we can build trust between the two.
Yes. Thank you very much. This is a very good question. One thing I would like to say is that we need to have a way of interaction. So we have many interactions. It can be community dialogues where they come and meet, discuss what are the health problems within the community, and the community health promoters who interact with the clients are able to bring the issues that are coming up from the community, and the health workers are able to say these are the issues we are having at the health facility emanating from the community. It could be that community, if there are many cases, or maybe it could be diarrhea, they can be able to say, is it something around water sources, or they are not boiling the water? And these are the health promotive initiatives that can be undertaken at the community level. So that is one. So one of them is having dialogue. So if you want for these two, community health and the link facility health staff, to work and to have, they need to bond. They need to have team buildings. So that's why we are calling up on having. We can have medical camps together, discussing and bringing the people together, and people to have forums where they can raise issues. So we can ask. We've been asking health facilities to have places where they can come and lodge their complaint or give their feedback on how they want their services to be improved and things like that. Yes, those are the things, two or three areas in my mind now.
And I think certainly we know communities know their own communities best. So when it comes to solving problems, they're probably in the best place to solve them.
Absolutely.
Without a doubt.
Yes, yeah. You normally say that that's why QI is about bottom-up approach.
Yes.
So you get solutions within the community. They are the ones who know how best to address. Is it something around transportation, around referral? Do they, for example, so when we are redesigning or reorganizing health services for improvement of services at the community level, it depends. We need to get the feedback from them and give them opportunity to give feedback freely without any intimidation or things around that. Yes.
Absolutely. Maybe my last question to you actually is about how do we sustain quality improvement activities? We have projects such as the See It, Do It project, where we're seeing some really good, strong, solid improvements. We're seeing trust built between the community and the facilities. These are all very positive things. How do we truly sustain these after the project funding disappears?
Yes, thank you very much.
And I know it's not an easy one to answer.
Yes. So sustaining quality improvement initiative starts from the national level. So we should have a robust national level team that is that supports QI for the counties. So by coming up with initiatives that are harmonized within one structure, existing structures, that is one. And then having a budget line to support those sorts at the national level. The same should be replicated at the county level. We've been asking counties to ensure that they have what we call county quality improvement teams with coordinators, not just at the county level, but also at the sub-county level. So that the county level can support initiatives now at the community level, at the dispensaries where they have 2 or 3 staff. So by building quality improvement initiatives or by having governance structures that are within the existing county structures, that is the only way we can sustain this. And then we want to start. We want the government to start funding we want to start resource mobilizing domestic resources so that we don't have to depend on partners all the time. So that these ones can go in supporting the QI initiatives. We normally say that you build from what you have and start from where you are. So quality is like a journey without destination. So let's improve quality. I have seen a number of us wants to do quality like a sprint. But quality is like a marathon where you take your time, improve incrementally, build on success after success, and you will be there. So you don't have to sprint. Let's do step-by-step process. And that's how QI is embedded within you plan, you check whether you are improving, and you do that one all the time in an iterative process.
And we know that the Kenyans are champions when it comes to marathons, don't we?
Absolutely, yes. And we learn from them. In fact, we should be inviting them to come and
Absolutely.
to our forums to give us insights on what it is required. Is it this discipline? Is it what they must be using quality improvement initiatives that we can borrow from them?
Oh, thank you, Dr. Kandia. I'm just going to ask you now your 3 key messages. I think you've already shared a lot of wisdom with us, but if there were 3 key messages that you want our podcast listeners to take home, what are your 3 key messages?
Okay, thank you very much. On my 3 key messages is on building leadership and governance that is robust within the county. So one thing that is important is that there should be a deliberate process in sensitizing leadership at the county level, at the health facility level, and also within the community work improvement teams, so that they understand. So that is one important thing for me. Then teamwork is an area that we need to work on. How do we ensure that the multidisciplinary team work together? They build on each other's strength, which is something that there's fear among that. It looks I'll outshine your boss or something like that. But we tell them this is very important. So let's want to have robust multidisciplinary team working together to ensure that quality. And it's not just at the hospital level, but at all levels, including at the dispensary level, at the health facility level. And then the last one is on using data. A quality improvement team is about driving improvement proactively using data. So data, keeping data, coming up with initiatives on how you can measure so that you know where you are going. Even if you make 1 unit or 2 units day by day. And the Ministry of Health has come up with tools on how measurement can be undertaken. There is a number of programs, and we are thinking of coming up with an virtual academy to support everybody to now understand quality.
Well, that's very exciting news. So basically, we're saying strong governance at the county level. So county directors, I hope you are listening to this podcast, and sub-county. We're talking about multidisciplinary teamwork, because we know quality cuts across all areas. It has to be multidisciplinary, and we're talking about measurement and data. Because how do we know if we've improved if we can't measure where we were to start with? Thank you so much for sharing your wisdom. I'm sure our podcast listeners will have learned a lot today. Thank you, Dr. Kandia.
Okay, thank you very much.
Let us do it now.